Okay, guys. So today we'll be starting with sarcoidosis. So,
Very high yield. Hello.
yes, sarcoidosis is very high. Yeah. So, one thing about sarcoidosis is that it's one of those chronic inflammatory diseases. So, it basically affects essentially all the organs in the body. But the inflammatory process typically can start from three parts. Any of the three: the lungs, the skin, or the lymph node. So, but in most cases, it affects the lungs. So, it's a chronic inflammatory disease that is associated with formation of granulomas because it typically involves the activity of the CD4 cells, that's the T-helper cells, and the macrophages, with little or no activity of the cytotoxic T cells. It has been postulated that the main trigger for sarcoidosis can be environmental exposure or environmental exposure to some antigens or some infectious diseases. So when they are exposed to the antigen, either from the environment or from the infection, you have the inflammatory response kicking in. So the CD4 plus cells comes in as well as the macrophages. They try to engulf, those antigen, and in the process, you start forming the granulomas. You guys remember that when you want to form a granuloma, it's just meaning an antigen that's been surrounded by macrophages. The macrophages are great together, they form giant cells, and that epithelial giant cells is being surrounded by the CD4 cells, the CD4 plus cells. So the T lymphocyte, the T helper cells are the outermost one. The middle one, the macrophages, then the particular antigen that you are dealing with is at the center. And of course, the kind of granuloma that we are expecting in sarcoidosis is a non-cystating granuloma. A non-cystating granuloma, different from the one you have in other infectious diseases. Maybe like tuberculosis, histoplasmosis, and all those ones. Sarcoidosis is non-cystating. There's no central necrosis here. Okay. Um, Now there are some peculiarities about this sarcoidosis that once you see them, you know that this is sarcoidosis they are talking about. So we've talked about the fact that the inflammatory process starts within the lungs. So you have the granulomas that we have talked about within that lung. They typically affect the lymph nodes within the lungs. And we remember that the lymph nodes in the lungs are called the hilar lymph nodes. Those are the lymph nodes that will find within the trachea, the area where the trachea is bifurcated into the main bronchus and they are entering the lung. So where the main bronchus enters the lung is the hilar region. We have some lymph nodes at that area. Those lymph nodes get inflamed in people with sarcoidosis. So the granulomatous inflammatory process is very predominant in those regions and it affects it bilaterally. So people with sarcoidosis have bilateral lymphadenopathy affecting the hilar lymph node. So once you
Oh, are you recording?
yes I am. Yes I am. So once you hear bilateral hilar lymphadenopathy, you are thinking of sarcoidosis. Okay? The inflammatory process can also spread to involve the lung parenchyma. That's why you can see coarse reticular opacity. So once you check your X-ray, you see coarse reticular opacity with bilateral hilar lymphadenopathy. Sarcoidosis. Sarcoidosis should come to your mind. Okay, there are some um, metabolic changes that happen due to this granulomatous reaction that happens in sarcoidosis. Number one, there's elevated activity of the ACE enzyme. So the angiotensin converting enzyme is released from those granuloma and it's being studied to be elevated in people with sarcoidosis. So ACE enzyme is actually being produced by those cells, the macrophages, the lymphocytes within the granuloma. So it's elevated. Number two, the macrophages, when they get activated, they exhibit increased activity of alpha 1 alpha hydroxylase. There's increased activity of 1 alpha hydroxylase. That 1 alpha hydroxylase means that you can readily hydroxylate your 25 hydroxy cholecalciferol to 125 dihydroxy cholecalciferol, producing vitamin D. So vitamin D becomes abundant, and the vitamin D can cause absorption of calcium and phosphate from the intestine. So it's been noticed particularly that the level of calcium rises in people with sarcoidosis. So they paint an history of somebody that is having fatigue, that's having dyspnea, you know, weight loss for a long time, maybe some rash, some bone manifestation, and they said they did some lab tests. There's elevated Hayes enzyme. You know, they because the person is also coughing, they did bronchoalveolar lavage. They noticed that the ratio of the CD4 to the CD8 cells is elevated. They are giving us clean charts for sarcoidosis. Sarcoidosis. Because we've said that this disease can affect other regions aside the lungs, the lymph nodes. It can affect the skin. If it affects the skin, they can present with some rashes. What are these typical rashes that you see? You can see what we call lupus penile. Lupus penile. So you just have this erythematous lesion within the face, just the area where you find your butterfly rash in SLE. So also spares the nasolabial. In fact, it's a fantastic differential for SLE. So that's why if you see them painting a rash involving the face, don't jump to SLE. That will distinguish you from another candidate that is not aware of sarcoidosis causing lupus penile. So can cause a rash that affect the face, the cheek, the forehead, just like SLE. That is lupus penile. What other rash can they present with? They can have erythema nodosus. And erythema nodosus is just like a very tender, painful, you know, nodular rash that you find within the chin. They are very tender. So what they say, there's rash in the legs, lower extremity, anterior aspect of the lower extremity that is painful, that is tender to touch. That is erythema nodosus that they are talking about. So, what else can they present? Because we have even talked about the lungs. It can affect the lungs, it can cause, because at the end of the day, when chronic inflammatory process happens within an area, fibrosis will set in. So they can cause interstitial lung disease in form of interstitial fibrosis. So that is why sarcoidosis is a cause of restrictive lung disease. Because at the end of the day, they bring about damage to the parenchyma, causing fibrosis from the chronic inflammatory process that's been happening. So we've talked about the skin, the lupus penile, the erythema nodosum. Some people will talk about granuloma annulare, but I don't want you guys to pay attention to that. It's not really high yield because they don't typically, come down with that. So we've talked about the lungs causing interstitial fibrosis. Then we go to the let's go to the face. So it can affect the eye, causing ocular uveitis. Uveitis is one of the common presentation of people with sarcoidosis. Uveitis. Still on that face, they can have Bell's palsy. So they can have a lower motor neuron lesion affecting the facial nerve. So facial drooping, you know, loss of nasolabial fold in that area, you know, just facial paralysis, mm? Bell's palsy, Bell's palsy. They can have uveitis, they can have joint problems, just like SLE. They can have joint problems or rheumatoid arthritis. So it's been described as rheumatoid arthritis like arthropathy because it also affects, the fingers, the metacarpal phalangeal joint, the wrist. In some instances, it also affects the ankles, the knees, but it usually affects, the fingers, the metacarpophalangeal joint, sparing the distal, just like what you have in rheumatoid arthritis. So I think these are, then parotid gland enlargement. So that phase one is usually more like a triad. They have uveitis, they have lupus penile, sorry, they have uveitis, they have Bell's palsy, they have parotid gland enlargement. So the Bell's palsy affect the face, the lupus penile affect the face, the parotid gland enlargement, parotitis, together the face. So they actually form syndromes. So these three things I've mentioned is actually like a syndrome. It's a syndrome. So they have different syndromes that they form, but I don't think because there are many manifestations for sarcoidosis. You can't learn everything. It's too much. So we should just pick the common ones that they want us to know. So if you just picture what happens in the face, lupus panel, Bell's palsy, the parotid gland will be enlarged, and what else can they have? Oh, then we go to the joint. They can have rheumatoid arthritis like arthropathy, the lungs, intestinal fibrosis, then the lab picture, elevated calcium because of increased vitamin D production. Then the rash, lupus panio, erythema nodoso. Yeah, so that's essentially what you have in the lab: elevated calcium, elevated ACE enzyme. Then if you do a bronchoalveolar lavage, you are going to find increase in the level of CD4 cells to CD8 cells. So your chest X-ray, you are going to see coarse reticular opacity, then bilateral adenopathy. Okay, Dr. Oluwatobi, you have a question.
Sorry, it was a mistake.
Okay. So you guys can see the histologic finding here. You can see that there's no area of necrosis. You can see all these white, blue like stuff. So that's likely the macrophages, with the T lymphocytes also surrounding it. Then you are not seeing any area of necrosis. You are not seeing any hemping, any central clearance. So this is non-cystating granuloma, which is typical of someone that has sarcoidosis. You can see the lungs. You can see like the hilar region where you have the trachea, the bronchial entering the lungs. You can see that area is looking opaque. So that's the hilar, adenopathy that they have. And you can see it's also affecting both middle zones of the lung, you know, that those are the coarse, opacity that you have. So you can also see here, the highlight region is affected in the CT, and also just like the X-ray, the middle zones of the lungs are both affected. This is typical of sarcoidosis. How do you want to treat them? Just give them glucocorticoid if they are symptomatic, because in most of the situations you might not even have any symptom. But once they are symptomatic, you have to take care of the process so that it doesn't escalate. Give them glucocorticoid acting as an inflammatory agent that can slow down the inflammatory process. Okay, so is this clear to us? And also for epidemiological reasons, it's common in females, black females, black females. That's just for epidemiology. Do you have any question on sarcoidosis? Okay. Sorry guys, can we still see my screen? Can we still see my screen now?
Yes. Yes.
Okay. Yeah, so the next inhalation
So,
injury.
Dr. Wawali, meaning that if the person is not symptomatic and maybe, for instance, it's like an incidental finding, it will still not be treated.
They
Is
will not
that
be
it?
treated. They will not be treated. Yeah, they will not be treated. They might not be treated. So,
Okay, and then for the causes,
mhm.
so what are we? I can see that we said it's immune mediated, but are there any like direct causes? Like, is it like
No,
occupational lung disease, sort
no,
of related to
no,
something? What's in the history?
no. There's no direct cause for sarcoidosis. In fact, the explanation for the trigger is more like postulation. It's believed to be from
Yeah, that
environmental exposure or from infection. It's not as if you have a
what
specific agent.
what exposure?
Maybe through environmental antigen, anything in the environment.
Okay,
So
okay.
there's nothing we can really pinpoint to that is responsible for that. So it's just
Right.
it's just you know environmental exposure. We don't really know the exact thing. We don't want to say it's idiopathic.
Okay.
So, but it's looking more
Okay.
like as if we don't know. We can only explain what we see, but we don't know the trigger for it. So that is sarcoidosis.
Mm,
That's sarcoidosis.
okay. All right. Thank you.
Yeah. So, inhalational injury and sequel. Inhalational injury is just more like injury that someone sustained, following inhalation of toxic agent like smoke, noxious stimuli like smoke. And you know that smoke contains so many things, you know.
Dr. Pawale, before I move on, I know that sarcoidosis is like, I actually think about it like amyloidosis or something like that, like maybe like a maybe abnormal protein deposition or something. So
Okay.
like in your explanation, I did not hear anything like that.
Yeah.
So is that's not it, Abby?
So it's not like
At all,
protein
at
is
all.
depositing here. You don't have protein. The only reason why sarcoidosis can, sarcoidosis is a granulomatous disease. You see, all those
Mm-hmm.
structures that is being affected is actually forming those granulomas there. You see, there's no particular structure that you biopsy in someone that has granuloma that's affected that you not find this non-cystating granuloma. You always see it. If you biopsy
Okay.
the nerve, you see there. So if there's
You
affectation
fixed
of,
it.
let's say there's affectation of the I don't know which organ that you have in mind, the heart. You are going to see this granulomatous inflammatory process happening in the heart, causing those
Okay.
restrictive heart symptoms that they are having. Do you get it?
Okay.
So it's the
Okay.
inflammatory process that is causing it. It's not deposition like you have in amyloidosis.
All right. Thank you.
Yes. So so inhalation injury um is one of the is a complication of inhalation of smoke. So smoke contains so many things: particulate matter, irritants, some noxious gases like carbon monoxide, like cyanide, like arsenate, like sulfur dioxide, so many of them. So from the heat of smoke, they can get burn. They can get burns from there. If there's inhalation of the particles, the particulate matter that's suspended within the smoke, or irritant like ammonia, it can also cause some inflammatory responses within the airway. So if they inhale that, you can have some inflammatory triggers, which can cause inflammation of the airways, particularly the trachea and the bronchi. So they can have what we call chemical tracheobronchitis. That one's just talking about inflammation of the airway. And of course, if you guys you know that if someone has inflammation, there's going to be release of inflammatory mediators, that will bring about increase in capillary permeability, increase in blood flow to that area to recruit more inflammatory cells, which explains edema. You know that edema is one of the cardinal signs of inflammation. So edema, pain, redness, and all those things. So from there, it can escalate to causing chemical pneumonia. So this chemical pneumonitis is just more talking about the particulate matter or the irritant getting down to the alveoli. So if it bypasses the airway and gets down to affect the entire lung parenchyma, they can develop pneumonia. So there's inflammation of the lung parenchyma causing the pneumonia, and subsequently it can affect the the respiratory membrane. We are going to shed more light on ARDS. When there's affectation of the both the alveolar membrane as well as the endothelium of the pulmonary capillary. So the endothelium of the pulmonary capillary as well as the alveolar membrane. So just picture that the alveolar membrane is up and you have next to it your endothelium of the pulmonary capillary. That is the site where gaseous exchange happens. So the gases move from the alveoli, diffuses across the alveolar membrane, which is formed by the type 1 pneumocyte, to move across the endothelium of the pulmonary capillary to enter the blood in the pulmonary capillary. So those two layers that it has passed through, those are the respiratory membrane, which includes the endothelium of the capillary as well as the alveolar membrane. That is damaging in an individual with acute respiratory distress syndrome. So this is different from the distress syndrome that infant exhibit. The one of infant is due to absence of surfactant. Here is not surfactant. It's actually due to a cytotoxic insult to the alveolar cells. So here from the inhalation of the noxious gases. So the inflammatory mediators that has been released cause increase in the capillary endothelial permeability. There's extravasation of fluid from the pulmonary capillaries into the alveoli. So that explains the entire process that happens in ARVS. We'll get there. We'll get there. So that's a very, very bad progression. And what do you see on examination? If you check their nose, you are going to see singed nasal hair. So that means that the nasal hairs will appear burnt, or you can see soot, soot within the mouth or the nose on examination. If you do a bronchoscopy, you try to put a scope, into the airway to check the tracheal as well as the bronchi. You are going to see evidence of inflammation, acute inflammation, especially during the first 18 hours after the injury. So you see cardinal signs of inflammation, redness, congestion, swollen areas like edematous area with deposition of the soot within the bronchioles. Then after 11 days, there's resolution. So within like 1-2 weeks, you have resolution of the inflammatory process. So that's that about inhalational injury. Um, Mesothelioma. Wow, mesothelioma. Okay. Ah, okay. Oh. So they said we should learn about mesothelioma next. I don't know what I should do now because mesothelioma normally should be after pneumoconiosis. Okay, so mesothelioma is more like malignancy of the mesothelium. So mesothelium is a form of epithelial lining that lines the serous cavities. The pleura is one of them, the peritoneum is one of them, the pericardium is the last one. So, but we are looking at one of the pleura now. So this is very high yield. We should pay attention to this. Mesothelioma is malignancy of the pleural lining. And the only cause that has been discovered to cause mesothelioma is asbestosis. Smoking doesn't cause mesothelioma. Asbestosis causes mesothelioma. Because asbestosis is the cause of mesothelioma, asbestosis itself is one of the pneumoconiosis, is one of the occupational lung disease. It occurs in an individual that has been exposed to asbestos dust for a long time. So asbestos dust, apart from its normal damage that it causes to the lung, it also affects the pleural cavity. I'm talking about the lung parenchyma now. It also affects the pleural cavity itself. It causes thickening and formation of plaques within the pleural cavity. So with time, those pleural plaques can undergo hemorrhagic transformation, causing hemorrhagic effusion. That's a form of exudative effusion. There's hemorrhage already. There's damage to um, the blood endothelial capillary. So there's a circulation of blood into the pleural cavity. So that's exudative. In transudative, you don't have damage to the capillaries. It's just hydrostatic force that is driving the fluid, like heart failure. That's transudative. Okay, I think we are still going to get to causes of pleural effusion. We understand that. So once you see hemorrhage, most likely it's going to be an exudative effusion because you have damaged a barrier that is causing the blood to leak in. And of course, it's going to share with pleural thickening because the pleural thickening will have been even be caused by the asbestosis. So asbestosis is just like a progression towards mesothelioma. What are the histologic findings? Mesothelioma is also one of the causes of psammoma body. So you are going to see concentric, laminated, calcified, lesions within your histology analysis. That represents psammoma bodies. We can find it in so many conditions. I know we know that. If we do electron microscopy, you are going to see polygonal cells. Now, what I want us to just pick here is that in addition to seeing the microvilli, we're also going to see component of the intermediate filament. So your desmosomes is one of the intermediate filament as well as tonofilament. So tonofilament winds around desmosomes. They wind around, desmosomes. Sorry, they are not intermediate filament. They are just like, connecting structures, addition body. So your desmosomes, is one of those addition structure that you have, and tonofilament surround your desmosomes. Tonofilament surround the desmosome. So what they help to do is to help us attach intermediate filament to one another. So one of the prominent intermediate filament that you find in someone with mesothelioma, joining those epithelial cells, is cytokeratin, especially cytokeratin. So cytokeratin is more like an intermediate filament. So we have different types, but the one that is prominent in mesothelioma is the cytokeratin type 5 and the type 6. So type 5, type 6. Because mesothelioma can resemble lung, cancer, the squamous cell carcinoma of the lung. They look very much alike. So one of the ways you can separate them is by doing histochemistry to stain for cytokeratin 5 or 6. It is always positive. It is almost always positive in all cases of mesothelioma, and it is never positive in your lung cancers. The carcinomas affecting the lung, they are not positive with that. So another marker that is also elevated in them is calretin. So we should not forget these two. Cytokeratin 5 or 6 and calretin, they are elevated in individuals with mesothelioma, and they can use it to separate the lung carcinoma. So tobacco smoking is not a risk factor for mesothelioma. Tobacco smoking is not a risk factor for mesothelioma. Asbestosis is the cause for mesothelioma. Okay. Yeah, so let's talk about the pneumoconiosis. So before we list those dusts, you know, there's something that was mentioned here about the position that they affect in the lung. This is IUD. Very important. It's a very quick way of narrowing what we are looking at. So if they tell us that there's a lesion within the upper part of the lung, okay, we are only thinking of three things: silicosis, coal dust, or beryllium exposure, berylliosis. If it's affecting the base of the lung, there's only one thing: asbestosis, asbestosis, asbestosis. Lower part of the lung, asbestos. Upper part, berylliosis, the co-worker pneumoconiosis, as well as silicosis. They affect the upper. So the way you can just remember it is, okay, asbestos, you use it in roof. That's the upper part of the house. So just inverse it. It affects the lower part of the lungs. And it is only asbestosis that affects the lower part of the lungs. So when someone has chronic exposure to asbestos dust, that is, and with eventual, pulmonary fibrosis, that is asbestosis. That's what it means. After developing the pulmonary fibrosis, because you have recruitment of chronic inflammatory cells, they tend to, gather around those asbestos dust. They tend to eliminate them, want to eliminate them, but it's very difficult to eliminate. So inflammatory processes keep occurring, and at the end of the day, you are not able to destroy that material. So you just form granuloma everywhere, and eventually you are going to lay down collagen that will bring about pulmonary fibrosis. So that's asbestosis. And asbestosis particularly has also been implicated in affectation of the pleural cavity, just like I mentioned. There's going to be thickening of the pleural cavity, and it's going to be actual formation of plaques. You are going to be seeing plaques within the pleural cavity. Plaques, pleural plaques that appear calcified, and they are located at the base of the lung, supradiaphragmatic, just above the diaphragm, at the base of the lung. So they appear heavy white, calcified, supradiaphragmatic or basal um, pleural plaques. So let's see what they look like. Oh, that image is not here. Oh my God, that image. I don't know. Maybe I have to bring my 2022 to my system. 2022 is what I use on my phone, and okay, there's a picture in 2022 that actually describes what this plaques looks like. This A is not really giving it, but they're just okay. Yeah, we can see it here. These are the plaques here, but they gave us a proper gross image. So these are these white things that we are seeing just at the edge, the pleural cavity, because pleura is surrounding the lung. You guys remember that it invests on the lung, so you are not you cannot find pleura in the center. So to be at the edges, just like we have here, this white deposition, they are the pleural plaques, every white. And so what are the things that can bring about asbestosis? What are the things where can someone get exposed to asbestos or asbestos containing material? Ship builders.
I've put the picture that you were referring to on the page. So
Okay,
in
thank you
case
very much.
anybody doesn't have it, yeah.
Thank you very much, Dr. Francois. So that's what it looks like exactly. So those are those, you know, plaques on gross examination. Well, this one that we have here is also high yield because you are most likely to get a CT image than a gross image. Well, you can also get a gross image. You can also get gross image in exam, but so it's good to have the knowledge of how it looks like those both on gross appearance and on imaging. So individuals,
So, Dr. Francois, that particular image you showed, that's not, we are talking about the asbestos. Is that the asbestosis in the,
yeah,
is it
Yes,
kind
that's
of,
asbestos related disease, the
um,
supradiaphragmatic plaques.
that is it. That's the
okay,
gross
so
picture.
those things are plaques. Those
Yeah,
things are plaques.
Yes,
they are the
So
yes.
I
plaque.
wouldn't have known that.
The what?
Thank you for sharing that.
Yes,
I said I
yes.
wouldn't have known that.
Mm-hmm.
Thank you.
Yeah. So individuals are working where they are building ship because the asbestos is very is an insulating material, so it doesn't get burned easily. It doesn't conduct electricity. So they use it to build ship. They use it in plumbing work and roofing. So, but I must also mention that it's also a component of engine oil. You know, engine oil. So mechanics can also get you know affected with asbestos related problem. I'm just mentioning that. So you guys already know the reason why I'm mentioning it. Mechanics, electrician, plumbers, builders are roof the houses and ship builders. They can all be exposed to asbestos. They can all be exposed to asbestos, and we know what it causes. So it causes pulmonary fibrosis because of the inflammatory response to that is going to eventually cause pulmonary fibrosis. And aside affecting the pulmonary parenchyma, it also affects the pleural cavity, causing thickening of the pleural cavity as well as formation of plaques that can transform, into malignancy, causing mesothelioma. So it can also cause bronchogenic carcinoma. Of course, something that causes pulmonary fibrosis can progress to cause a lung cancer. Almost all the things that cause pulmonary fibrosis at the end of the day can cause lung cancer. So they can cause pulmonary carcinoma, they can cause a bronchogenic carcinoma, but the risk of bronchogenic carcinoma is far higher than mesothelioma. Even though mesothelioma is only caused by asbestosis, the mesothelioma is still a very rare disease. The risk of bronchogenic CA is far higher than mesothelioma with asbestos related. So if they put it there that what's the most likely cancer that someone that is exposed to asbestos is going to develop, it's still lung cancer. It's still lung cancer, not mesothelioma. Okay, it's still bronchogenic CA and not mesothelioma. It also increases the risk of Kaplan syndrome. So you guys remember?
Dr. Vale, sorry, can you kindly repeat the last point? I missed it. You said what about
Okay, so I said that
bronchogenic?
asbestos is the only cause of mesothelioma, malignancy of the pleural cavity, the pleural lining.
Okay.
But
Okay.
asbestos can also cause bronchogenic carcinoma. And
Okay.
the risk of bronchogenic carcinoma is far higher than mesothelioma because mesothelioma is a very rare, extremely rare carcinoma, tumor,
Okay.
malignancy. It's
Malignancy.
not a carcinoma. Yeah, it's a very rare.
A malignancy.
Yes.
Okay. All right. Thank you.
Yeah. So, someone that develops asbestosis or asbestos related disease, typically they manifest at the lower lobe. So if you are going to see the pulmonary fibrosis, you typically see it at the lower lobes of the lungs. That's why you haven't seen so lower lobes. That's just that. Then another stuff you are going to see when you do your analysis, histologic analysis, after you've obtained sample of the sputum from the lungs by your bronchoalveolar lavage, is what we call ferruginous bodies or asbestos body. Ferruginous body or asbestos body. Do you have something? Yeah, so this is what it looks like. Ferruginous body or asbestos body. Now these bodies are just portions of the asbestos that's been inhaled, having protein and iron deposited within them. That is it. Protein and iron deposit within these asbestos fibers is what we call the ferruginous or the asbestos body. Now, this is the reason, because of the fact that it contains iron, that is the reason you can identify these bodies clearly when you do your Prussian blue staining. You guys should not forget that. So Prussian blue stain is what you use to visualize those ferruginous body, and they appear dumbbell, after you've obtained an alveolar sputum sample with your bronchoalveolar lavage. So don't forget that iron protein deposit within the asbestos. You visualize it with your Prussian blue stain. And of course, we know that um, uh, the asbestos can affect the pleural, causing the thickening. So there's high risk of developing hemorrhagic exudative pleural effusion, particularly in people that have the mesothelioma already. There's high chance of them having concomitant hemorrhagic pleural effusion. There's something we call Kaplan syndrome. Almost all of them can cause Kaplan syndrome. Kaplan syndrome is just talking about rheumatoid arthritis with pneumoconiosis. So you find features of rheumatoid arthritis in an individual, and you're also seeing features of pneumoconiosis, in an individual. So those pneumoconiosis actually appear as intrapulmonary nodules. So if you do your CT, you see those intrapulmonary nodules. You know that, okay, this is likely to be Kaplan syndrome. So those two things are coming together in an individual, Kaplan syndrome. Yeah. So berylliosis, yes, we don't have too much story with berylliosis. Just like we have said, the only type of the pneumoconiosis that affect the lower lobe is the asbestosis. The other ones affect the upper lobe. The other one affect the upper. So upper lobe is constant feature to the other ones. What is about berylliosis? It's only granuloma. That is all. Granuloma is just the only thing that you find with your berylliosis. So beryllium is one of those things that the equipment that we use in building our aircraft. So and some manufacturing industries, just strictly aircraft majorly beryllium. So if someone has exposure to the beryllium dust, inflammatory cells is also going to respond to it. The same process happens again, and they tend to form granulomas, which is non-syssating. Of course, it's not an infectious process, so we are not expecting it to be syssating. So it's going to be non-syssating on histology, and they also respond to glucocorticoid. So if you give glucocorticoid, just like sarcodosis, you can suppress the inflammatory response. So the only thing about berylliosis is just granuloma. I think we have an histology picture. Yeah, so this is it. As we are seeing granuloma, you know. that is non-sedating. There's no central clearance, no central necrosis. That's periodontitis. It can increase it because it can also cause pulmonary fibrosis. The person can develop, portal hypertension. They have high chance of developing pulmonary, and also it increase the risk of cancer. So we've said it. Pulmonary fibrosis can cause cancer. From the pulmonary fibrosis, they can have heart failure. So that's that about berylosis. The co-worker pneumoconiosis is also one of the common ones that it has. But what you just find there is just like is more like black lung disease, and it's due to chronic exposure to coal dust. So people that work in coal industries or coal mining and all those things, they can be exposed to this, coal dust for a long time. And when they inhale those coal dust into their respiratory tract, the macrophages are going to respond to them, tend to form like just like the way they do to asbestos and beryllium. They engulf those carbon component, which will eventually lead to chronic inflammation and fibrosis at the end of the day. So when you bring out the lung and you are looking at it grossly, it will be as if the person has smoked for a long time. It's going to be black due to the deposition of the carbon. The coal contains high amount of carbon, so the carbon deposit makes it appear black, and also confers high risk of Kaplan syndrome. So you are going to see intrapulmonary nodules from the chronic inflammatory process, as well as features of rheumatoid arthritis. So once we are seeing an individual having both of them, that's what we call Kaplan syndrome. The clincher that I just want you guys to pick for this co-worker pneumoconiosis is that we are going to see small round nodular opacity. I don't want to know the test that you are using. That is what you are going to find. So it can't go beyond that. That is the clincher. Small round nodular opacity in the upper lobe. That is what you want to hear. Small round nodular opacity on imaging co-worker pneumoconiosis. Then there's also something called anthracosis. Anthracosis is also, the black lung disease, but it's just like a milder form. It hasn't caused this pneumoconiosis, because pneumoconiosis occur when there's now fibrosis, when there's lung damage. That's why you call it pneumoconiosis. But here, you don't have lung damage here. You are just having inhalation of that coal dust, and it usually is asymptomatic. So it hasn't actually caused any lung damage. So anthracosis is just more like, exposure to the coal dust for a long time without any severe damage, and it is symptomatic. So when there's severe damage like fibrosis, you tend to have what we call co-worker pneumoconiosis. So don't forget that small round nodular opacity. So if they describe that in our question, small round nodular opacity, you know that it is cool stuff that they are saying. They tell us the only thing that they found there is just non-sedating granuloma, and the person is working in a plain building company, that is berylosis that they are saying. If they tell us that they find some golden bound fusiform rods, upon use of a particular stain, they are likely talking about ferruginous body, which is affected with asbestos. Yes,
Sorry, did you say that the anthracosis is like the cold, that
yes,
it's not
yes.
symptomatic?
Yes, it's like a cold that is not symptomatic. So you typically find that in people that are exposed to areas of air pollution. Maybe they burn things a lot in that area. It's not as if they are actually going to coal mining. You get, so anthracosis can even occur in people that are not mining. Maybe they are just living in an area that they burn, substances a lot. So one of those components is also carbon. So they can inhale those carbon dust for a long time that can cause, anthracosis. The lung will might still be black, but they will not develop any serious inflammatory damage to the lung. So if someone get exposed to what's it called, this coal dust for a long time and there's not lung damage, that's why we have pneumoconiosis. But in anthracosis, there's no severe lung damage. That's why they are asymptomatic, and you don't typically get it from mining. It's just exposure to areas that is polluted, from severe industrial burning or something, having that exposure to that sooty air that contains carbon. That is anthracosis. Do you get it, Dr. Zulia? So that's the difference between anthracosis and
Yes.
pneumoconiosis. In pneumoconiosis, you're already having the lung damage, the fibrosis. In anthracosis, you are not. So it's asymptomatic. Silicosis is the last one. Silicosis comes out a lot. It comes out a lot. So silica is one of the components of sand. So people that work in areas that they do sand blasting, they can be exposed to silica dust. People that work in foundries, so foundries are areas where they smelt metals, where they use. So those stuff that they use to, make the metal sharp and all those things, they can release this silica dust. So, and also people that work in mines can also be exposed to silica, dust. So this silica one has some extracts that we need to pay attention to. Just like we've said for the other ones, once you inhale the silica dust, the macrophages, the alveolar cells, the alveolar cover cells, these are the macrophages that we are talking about. They respond to them. They try to engulf those silica, and chronic inflammatory process starts occurring. So you recruit fibroblasts into that area. Fibroblasts lay down collagen so that we can cause fibrosis. So fibrosis also happens with silicosis, just like the way it happens with co-worker, with berylliosis and asbestosis. Fibrosis happens with almost all of them. But there's something else about silica. Very high yield. Silica inhibits it disrupts the activity of the phagolysosome. The phagolysosome are there to help you secrete some interleukins that can help us digest those engulfed material within the phagosome. So what happens is that when the macrophage engulfs that material, that silica, they form phagosomes. The phagosomes will merge with lysosome, because lysosome contains digestive enzyme to help us digest those silica agents. But silica has been found to be something that inhibits that fusion. It doesn't allow the phagocyte to fuse with the lysosome. Even the fusion, it impairs the activity of the macrophage to even engulf. So, and phago lysosomal fusion and digestion is important for controlling tuberculosis. So that is why people with silica have higher chance of developing tuberculosis, like more like 4 or 5 times than someone that has no exposure to silica, or the person someone that doesn't have silicosis. So if someone has silicosis today, one of those things that you want to rule out is tuberculosis in the person because of this disrupted phagolysosome action. Your macrophages are very, very important to take care of tuberculosis. Just like this dust, once someone inhales tuberculosis antigen, your macrophages are the first cell that is going to respond to it. They engulf it. The next thing is to fuse that phagosome that will form from engulfing the tuberculosis with lysosome, so that you can digest that tuberculosis antigen. So if you cannot digest that bacteria, that means that tuberculosis will just be playing around in the body, and it can disseminate, go to different organs within the blood and cause disseminated tuberculosis. So that's why people with silica, have impaired phagolysosome activity, and makes them predisposed to developing tuberculosis. So they can have pulmonary fibrosis, which can cause heart failure. That pulmonary fibrosis can progress to developing lung cancer, and at the same time, they can have Kaplan syndrome, just like we've said for all of them. What is the clincher for silicosis? The clincher for silicosis is presence of the eggshell calcification within the hilar lymph nodes. Once you see that statement, that is silicosis. You are going to have eggshell calcification in the hilar lymph node. So once you show the X-ray, we are seeing calcification within the hilum, area of the lung. So, and of course, in the history, they will have given us an occupational clincher that the person is working in a mine or foundry or sandblasting area. You know that this is silicosis you are definitely looking at. Eggshell calcification. So if they say small round opacity in the upper lobe, you know what they are talking about. That is coal dust. If they describe ferruginous body, asbestosis. So that is all about the pneumoconiosis. So let's go to acute respiratory distress syndrome. So acute respiratory distress syndrome is more like a complication of so many things. The common cause for acute respiratory distress syndrome is sepsis, and there's an infection. There's a disseminated infection. That's why you call it sepsis. It's already disseminated in the blood. So of course, blood is going to get to the lungs. So from there, the inflammatory cytokines will be introduced to the lungs. Another cause is aspiration pneumonia. So there's aspiration of gastric content directly into the airway, getting to the alveoli, causing alveolar insult, which brings about release of pro-inflammatory cytokines that start, the cascade. Burns, burns can also bring about release of, cytokines. Trauma to the lungs can bring about alveolar damage with release of cytokines. Pancreatitis has been known to be a condition that releases a lot of cytokines into the bloodstream. It can also cause acute respiratory distress as one of the presentation. It can cause so many things. It's disseminated because pancreatitis, you have release of those interleukins, those cytokines into the bloodstream, they can go anywhere. They can even cause acute kidney injury. They can damage, the lungs. They can, anything you can think of. Pancreatitis is a disseminated condition. When there's overwhelming release of those interleukins from pancreatitis, you can have affectation of so many organs. And the people that are drowning too, there's a lot of fluid within the lungs, there's lung damage, release of the inflammatory cytokines. So that's the common pathway. Anything that brings about alveolar insult or excessive exposure of the alveolar capillaries to inflammatory cytokines, that will drive recruitment of neutrophils. So neutrophils is actually very important because it's an acute event. This is not a chronic event. That's why you don't have fibrosis here. Fibrosis will be a later thing. So it's an acute event. So neutrophils is actually the immune cell that we are looking at. So there's recruitment of the neutrophils. They release the reactive oxygen species as well as protease enzymes. So this protease enzyme is actually very, very important. This protease enzyme as well as the ROS and other cytokines that they release cause damage to the capillary endothelial lining. That is very, very important. So when it releases the protease enzymes and the cytokines, they cause the damage to the capillary layer that I've talked about. There's endothelial cells lining the pulmonary capillaries. So when they are damaged, there's space for extravasation of fluid, blood, within the capillaries to get into the alveoli. So they are introduced directly into the alveoli, and they are protein rich. So when this protein rich fluid gets into the alveoli, it causes ironization. So ironing is actually caused by anything that deposits protein. That's it. Once you are seeing ironing, that's likely to be from protein deposition. So um, there's ionization of the alveoli. That's one of the findings you see, in someone that has ARDF. You do a biopsy, you're going to see those hyalinization, those hyaline material within the alveoli. Although you don't do biopsy, but if you do the analysis, you are going to see them. So, and this is due to extravasation of the protein-rich fluid from the alveoli due to damage to the capillaries. So when you form this hyaline membrane, the problem has started happening. You have started the process of destruction of the alveoli. At the same time, the protease enzyme is also going to damage the elastin fibers within the alveoli. Then the extravasation of fluid, apart from forming the hyaline membrane, is also going to cause pulmonary edema because there's going to be fluid overload within those pulmonary parenchyma. There's going to be fluid condension in the lungs, but it's going to be non-cardiogenic. How do you know? If you measure the pulmonary capillary wedge pressure, it will be normal, because in someone that has cardiogenic pulmonary edema, the problem is actually coming more from the left side. Let's say the person has a mitral stenosis. There's back log of fluid from the left atrium that gets transmitted to the pulmonary vein, then to the pulmonary capillary, to the pulmonary artery. So when it's backlogged within the pulmonary vein and the pulmonary capillary, they can extravasate into the alveoli, causing the pulmonary edema. You will call that one cardiogenic, because if you measure the pulmonary wedge pressure, the pulmonary capillary wedge pressure, which is talking about the left atrial pressure, is going to be elevated. But in someone with ARDS, your damage is directly to the alveoli. It's not coming from the heart. It's not coming from damage to the left side of the heart. So your pulmonary capillary wedge pressure will be normal. That's a way you can differentiate between a cardiogenic pulmonary edema and a non-cardiogenic pulmonary edema. You are going to have pulmonary edema in ARDS too, but it's going to be non-cardiogenic, evidenced by normalization of the pulmonary capillary wedge pressure, and evidenced by presence of hyaline membrane. Don't forget that, the protein-rich fluid that is entering the alveoli, causing hyalinization of the alveoli. So what is going to happen at the end of the day, because this process is also going to cause damage to the pneumocytes that are found within the alveoli. But one thing about the type 2 pneumocytes, that they are highly resistant to damage. But when an insult to the alveoli happens, their function is kind of reduced. So they are more concerned with the repair. That's what they do. So their synthetic function of releasing surfactant is reduced. So there's reduced production of surfactant from those type 2 pneumocytes because of the congestion within the alveoli. And you guys remember that we said surfactant helps to reduce surface tension. When there's a reduction in surface tension, you are reducing elastic recoil, you are increasing the compliance, of the lungs. So if there is loss of surfactant, that means surfactant tension increases. you know, compliance of that lung will reduce. So conglomeration of all these problems, reduction in the compliance, congestion of fluid there within the lungs, the ionization of the alveolar membrane with destruction of the alveoli, we are going to have a VQ mismatch. So we are just going to be having perfusion of the lungs without any ventilation of the fluid or the blood that is passing through the capillary. There's not going to be any movement of air from the alveoli into the lungs because you've damaged almost all the you've damaged the membrane. Part of the membrane is the capillary endothelium. You've even damaged the alveoli itself that's supplying the air. So there's going to be VQ mismatch. When there's VQ mismatch, there's hypoxemia. Hypoxemia will cause hypoxia, reduced delivery of oxygen to the tissues that brings about hypoxic vasoconstriction. That will increase the pulmonary vascular resistance. That will bring about pulmonary hypertension that can progress to form. If that continues for a while, it can develop into pulmonary hypertension. So, the loss of surfactant with the ventral alveolar collapse is very, very important for us to remember. Please, we should not forget that. Due to damage to the type 2 cells. And the one for the predetermined fat is due to immaturity. They are not mature, they are immature. So the pneumocytes are not yet formed, so they are not being able to synthesize a lot of the surfactant. So the surfactant can help us explain why there is a collapse. There's another mechanism. Some also talked about the fluid within the lungs explaining the collapse, but that's involving a little bit of physics, and I don't want to bother us with physics now. So let's just tailor that lung collapse to the loss of surfactant. You guys remember the way I described that surface tension. So I told us to picture surface tension as force that is trying to bring the lungs, the alveoli, towards each other, inward. If we picture it like that, we cannot forget. That is the same way I want us to also picture the elastic recoil. If we picture it like that, we cannot forget it. The surface tension and the elastic recoil, they are going in the same direction. They are trying to bring it inward. So just imagine that you are now having loss of surfactant. That means that there's nothing to stop the surface tension. That means you have unopposed force bringing the lungs inward. So that means that they are going to collapse on themselves. That is it. That is it. So these are the causes that we mentioned. What is the diagnosis? Diagnosis of acute respiratory distress syndrome is a diagnosis of exclusion. You have to exclude so many things like heart failure, fluid overload, anything that can cause congestion of the lungs before you can say that this is acute respiratory syndrome. So what are the criteria that you must meet? Number one, there's an acronym ARDS. ARDS. The A is abnormal chest x-ray. So you are going to find bilateral lung opacity. There's going to be opacity from the edema. So you guys know that someone that has edema, there will be opacity because there's fluid accumulating in that region. So you're going to have bilateral lung opacity, which is the abnormal X-ray. There's going to be respiratory failure within 1 week of the alveolar insult. So because it's an acute process, so it doesn't take 2 weeks, it doesn't take 3 weeks, it doesn't take a month. It happens almost immediately. So within a week, you are going to see symptoms of respiratory failure. What are these symptoms that we are talking about? Dyspnea, difficulty in breathing, tachypnea, uh, cyanosis, that's going to be appearing blue, hypoxemia when we do the blood gases analysis. So those are features of respiratory failure in response to the alveoli injury causing the VQ mismatch. So what else can we also do? That's the D. The D, decrease PaO2 to FiO2. So, Dr. Zuliat, someone that has acute respiratory distress, acute respiratory distress syndrome, what do you think will affect? What do you think will happen to the fraction of inspired oxygen, fraction of oxygen in inspired air, FiO2, fraction of oxygen in inspired air? What do you think will happen to it in acute respiratory distress
Fraction
syndrome?
of oxygen. The fraction of oxygen in inspired air is going to be the same
It's
thing.
going to be the same thing. It's going to be the same thing. So that means that we are saying that the PiO2 is also going to be the same thing, right, Dr. Zulia?
Yes.
If the
Yes.
PiO2 is the same thing, that means that
Sorry, in what condition?
in ARDS, in ARDS, hmm, so
Okay.
the FiO2 is going to be the same, the PiO2 is going to be the same. The P big AO2, that is the partial pressure of oxygen
Really.
within the alveoli, is also going to be the same. The problem is getting that
Okay.
air within that alveoli to the arteries. That is the thing, to get it into the pulmonary
So Dr.
capillary.
Babrali, there is an insult to the alveolar.
That's what I was saying. That insult to
How
the
come
alveoli shouldn't
the
it reduce the
alveolar
PaO2?
Ah, oh my God, you guys, you know, And we have explained this thing, guys. I've told us that the way we look at all these things is to, because if you are saying there's an insult to the alveoli, that means that we are saying that the big A will be affected. Sorry guys, sorry the way I responded. I'm not trying to criticize you, so I'm going to shed more light. So Dr. Oluwatobi, that means that we are saying that, okay, that means we expect the big A to be affected, right, Dr. Oluwatobi? That's what we are
Yes.
saying. So that
What
means
I'm
that
trying to understand is, so the this thing, the ventilation, like I feel like there's
okay.
there's an injury to the lungs.
So the reason why your PaO2 will not be reduced is that this person is going to hyperventilate to maintain the PaO2. So that's why I keep saying it, that the way you can, don't worry yourself about insult to the lungs or insult to anything. The only thing that can affect your big A, your alveolar pressure, is anything that can cause, either you are taking in air that is
Sure,
containing
and high
PaO2,
altitude.
or you are hypoventilating. That is it. Once you can
High
hyperventilate,
altitude or hypoventilation.
so provided that this guy is not hypoventilating, there's no affectation to that PaO2. It will not be affected. And one of the response to the hypoxemia here is hyperventilation. Because of that hyperventilation, you are going to be bringing out CO2. So that means that the level of PaCO2, that is the level of CO2 in the arterial blood, is going to be what? Is going to be low. If you
No.
slot PaO2 in the formula that we gave, if you guys remember that formula, do you guys remember that formula? PaO2, P big AO2 equals PiO2, that is the partial pressure of oxygen in the inspired air, minus PaCO2 over
CO2.
respiratory quotient. So if you're
Yes.
hyperventilating, what happens to the PCO2? It drops.
It will be low.
It will
Yeah,
be
it will
low.
be low.
If it drops, what will happen to the PaO2 at the end? Hmm?
It will be high.
So guys, I know that it can be confusing, but once you see something, the next thing that you just think in your mind is, okay, let me see. Can I explain what will happen to the big A or the small A? Now, if this condition happens, will this person hyperventilate? If the person is going to hyperventilate, forget. Your PA big AO2 is going to be normal. That's why pneumonia, pulmonary edema, the other insult, they are going to eventually lead to, because the patient with gaps, the person will try to hyperventilate to bring in air due to that alveolar, you know, due to the VQ mismatch within the alveoli causing the hypoxemia. In response to that hypoxemia, they are going to hyperventilate to bring in more oxygen, and in the process, they are going to bring out more CO2. And we've known that formula that they've shown us, connecting PCO2 to our alveoli arterial pressure. PCO2 is one of the major determinants of it. So if PCO2 is low, that alveolar oxygen pressure is going to be, because that one is just talking about, maybe let me just stop there, guys. Let me just stop. But Dr. Oluwatobi, do you get it now? So it's actually due to the hyperventilation that they experience. Do you get it?
So, so I think
So
basically
that
what
means the
go on, Dr. Toby, please. Go on.
okay, so that means the primary insult actually affects the alveolar, but it is just that there's a response that makes it equilibrate. That's what you're saying.
Yes. So that it will not
Okay,
affect.
thank you very much.
So that it will not affect
The the arterial, the alveolar oxygen.
the alveolar oxygen. The alveolar oxygen. That is it.
Thank you.
But we also said here that the endothelium will be affected. Endothelium of the capillary of the intestine will be damaged. Wouldn't
Yeah.
that affect the distribution
Exactly. So
of
if the endothelium is damaged, that means that you have damaged the respiratory membrane. There's no way oxygen can get into the blood. So the small A will be
mm-hmm.
reduced. Do you get it? The small A will be
Is that
reduced.
the small head, the small that's the P small AO2, right?
Mm-hmm.
It will be reduced,
It will
right?
be reduced, yes.
Yeah, that's what I'm saying now. But you said it will not be affected now.
No, we said big A. It's big A that we are talking about.
Okay.
That's why
I
I'm,
was
I'm
shouting.
that's why I'm trying to show us that formula. See, this is the formula that I'm trying to show us. This is the formula that I'm trying to show us. You can see that this is the alveolar gas equation. This equation is what will influence the alveolar gas, which is the concentration of oxygen within the alveoli. These are the parameters. the amount of oxygen that we are taking from the inspired air, if it's low, PaO2 is going to be low. And one thing that can make PiO2 reduce is when somebody is breathing at a higher altitude, PiO2 is going to be reduced. Okay, so aside the PiO2, what else can affect the partial pressure of oxygen in the alveolar gas? The concentration of PaCO2, that is the concentration of CO2 in the alveol in the artery. And we know that one thing that can influence that one is hyperventilation. If someone hyperventilates, the PaCO2 is going to drop. You guys remember that, forget that the alveoli stuff is damaged. You guys remember that we mentioned that CO2 is not what?
Diffusion limited.
Yes.
It's not, it is diffusion. It is
It,
not
it, it
the.
It is diffusion. It is diffusion limited.
no,
It
it's
is
not
not
diffusion
diffusion.
limited.
No, it's not diffusion. It's
It
CO
is
that
not.
is
Is
diffusion.
it the other? Oh, CO2. CO2.
CO.
So sorry. So sorry.
But this is
Yeah,
perfusion limited.
exactly. So the reason why CO2 is not diffusion is that CO2, we know we mentioned it that the diffusion of CO2 is like 20 times that of oxygen. Once it gets there, it don't
Mm-hmm.
diffuse. It will
Mm-hmm.
take the lung to be damaged entirely for you not to be able to get your CO2 out. The little space that it has is going to find its way outside into the atmosphere. You get it? It's 20 times that of oxygen. So that is why conditions like pulmonary fibrosis will still be causing hypoxemia, but it has to get very severe before it can cause hypercapnia. You guys remember that day that we mentioned oxygen as being both perfusion limited and diffusion limited,
And perfusion limited. Yeah,
but CO2 is not diffusion limited because its
it's just
diffusion rate,
perfusion.
exactly, because diffusion rate is very high. It's 20 times. It diffuses very fast. So that means that even this alveolar stuff cannot stop it from going outside. Because that's another angle we can look at it that shebi we are saying hyperventilation, but shebi na person wey get alveoli go hyperventilate. Because of the high diffusibility of CO2, it will still find its way outside to go into the alveoli and dilute the oxygen there. So at the end of the day, it's going to reduce the partial pressure that oxygen will be exerting in that alveoli because of the hyperventilation.
Okay.
So always remember about that formula. That formula will always help you to know what is happening. So that is why these guys cannot actually cause a normal AA gradient hypoxemia. They will not cause normal AA gradient. They will rather cause increased AA gradient hypoxemia. Do you guys get it now?
Yes.
Okay. So,
Thank you.
yeah, you're welcome.
Okay.
So, decreased PA small a O2, that's the arterial over the fraction of oxygen in the expired air. So we are just deciding to pick FiO2. That's what they pick. We can pick PiO2. Anyone. It's all of them. They are representative of each other. So that ratio is expected to be more than 300, but in someone that has ARDS, is going to be less than 300. It's going to be. I think the reason why we are picking FiO2 maybe because of the fact that FiO2 is always constant, like 21. So you expect the ratio to be more than 300, but because of the reduction in the PO2 in ARDS, the ratio is going to be less than 300. So the hypoxemia is actually come from intrapulmonary shunting and diffusion abnormality. So diffusion abnormality from the fluid that is there, the damage to the endothelium, preventing gas from the oxygen from moving from the alveoli into the capillaries. Then also because of that problem, you are going to having shunting of blood. So blood is going to try to move to areas that are well ventilated so that they can get blood. So you are going to have shunting of that capillaries towards capillary blood to other capillary that are well ventilated. So that is why we are actually saying that for us to have severe mismatch, the entire lung has to be not ventilated. You don't even have any area that is ventilated for you to have severe ventilation perfusion mismatch, and that most likely the patient will have died because there's not even giving the oxygen to the capillary. So that's that. So the shunting, you try to divert the blood towards areas that are ventilated. That's the shunting that we are talking about here, the intrapulmonary shunting here. Then diffusion abnormality because of fire, oxygen cannot. So you know that if you divert the blood from those poorly ventilated area, they are already contain deoxygenated blood. So if they go to mix with other ventilated area, it's going to dilute those blood and it's not going to be 100% ventilated. So it's still going to cause hypoxemia. So that is it. That is it. Please, guys, please, I need to know that you guys understand what I'm saying.
So my own is, why is it 300? Is it that when this calculated it, it was 300, or like 300 is like a constant that they are relating to?
No, yeah, the 300 is the normal value that we expect when you do the calculation. So me, I didn't bother myself
Okay,
finding out the reason why it's 300. Do you get? So because I
okay,
can remember
okay.
it in
All
my
right.
mind. So it's just 300 as the value of this normal stuff. So exactly. So it should be more than 300. It should be more than 300. More than 300. So,
Mm-hmm.
but in them, it will be less than 300. So that is that. But you understand the shunting I'm saying? You understand the shunting?
Yeah, it's just basically the response of the lung to hypoxia or hypoxemia
Exactly.
normally. So it will shut down the one that is bad and increase the one that is good,
So they will move it to the one that is
right?
good, and exactly, you know that that one that is bad is shunting blood that is deoxygenated to the ones that are good. So
The one
it's
that
going
are
to
good, so it will
it will
have like an imbalance, like a
exactly.
deficient
So you
abnormality.
moving deoxygenated blood to area of 100% oxygenation is going to reduce it to like 80. So that is it. So that's the way it is. Um So, what are the consequences? Impaired gas exchange, of course, that's what is contributing to the hypoxemia from the diffusion abnormality, reduction in the lung compliance due to destruction of the elastic fibers from the proteins. These neutrophils are going to release their proteins that destroys the elastic fibers, reducing lung compliance so they cannot stretch. And also, pulmonary vascular resistance is going to occur. Increase in pulmonary vascular resistance will occur due to hypoxemia. So, there's going to be pulmonary vasoconstriction that can cause pulmonary hypertension. Pulmonary vasoconstriction due to hypoxemia that causes hypertension. Okay, so these are the typical images that you see on your histology. You are going to see areas of destroyed alveoli. You can see that these are abnormally dilated and widened alveolar spaces. So these are the typical findings that you see on histology. How do you want to treat it? You want to manage the underlying cause. Is it sepsis? You want to find out and treat it. Is it pancreatitis? Is it burns or aspiration pneumonia? You want to treat that cause. Then you want to help the patient because the lung is going to collapse. Because when there's loss of the elastic recoil, when there's loss of that elastic fiber, they are going to, collapse. Uh, no, that's not what I'm supposed to say. So, you know, because of the loss of the surfactant, not the elastic fiber, sorry, because of the loss of the surfactant, you are having unopposed elastic recoil, so it's going to make the lung collapse. So, and that happens during expiration. So, the activity of the elastic collapse is more during expiration. That's when you need elastic recoil. Elastic recoil is needed during expiration to bring the hair out. So, and so in people with the loss of surfactant, surface tension and elastic recoil is kind of exaggerated. So there's high chance of the lung collapsing during expiration. So what do you want to do? You want to place them on mechanical ventilation so that you can deliver a very high end expiratory pressure. This PEEP is positive end expiratory pressure, so that at the end of expiration, when you're having that elastic recoil, you don't want that recoil to happen and those lung collapsing. So you want to maintain a positive transpulmonary pressure to keep them open. So that is it. That is what is happening there. So that's why you use
What
positive.
difference again? Did you say positive transpulmonary pressure?
Yes, you want to create an increase in the positive transpulmonary. You know that positive transpulmonary pressure is what keeps the alveoli open. You remember when we were talking about the alveolar pressure and the intrapleural pressure. Do you remember?
Mm-hmm.
So the
But man,
transpulmonary
like it's because they wrote PEEP, yeah. So I'm trying to look at how the
no,
mnemonic works.
this is positive end expiratory pressure. That is at the end of expiration, the pressure that is within the alveoli that is keeping it open. Do you get a positive end expiratory pressure? So that it doesn't, you need a positive pressure to keep the alveoli open. Do you get?
Mm-hmm.
So that's like the transpulmonary pressure. It has to be positive. If it's not positive, the alveoli will, shut up. Okay, let's look at this. Let's look at this. The the transpulmonary pressure is what? Is the difference between the alveolar pressure and the intrapleural pressure, right? So that means
Okay.
that if the alveolar pressure is increased, the transpulmonary pressure will be increased. Do you get it? So if you deliver a positive end expiratory pressure, that means that you are delivering a positive pressure at the end of expiration to the alveoli. You agree with me?
Sorry, I don't know the time. Sorry, Dr. Baba, the terminologies are kind of mixed up in my head. So now, like the way I used to know it before is that we used to have a negative pressure, like that is coming from like the, should I say, the chest wall, or the,
The
is it
pleural cavity, the pleural
the
cavity.
pleural cavity? Yes, the pleural cavity, and there's a positive one that is coming from like the alveolar, like when the air comes in. So which one is it that you're talking about now?
Okay. This pressure is what you give when you mechanically ventilate. Do you get it? When you place someone on
Okay.
mechanical ventilation increases pressure delivery to the lungs. Do you get it?
Mm-hmm.
Now,
Mm-hmm.
that pressure is a positive pressure. That's another fact that you need to know.
Okay.
Then the third fact that you need to know is that that pressure is delivered at the end of expiration.
Okay.
Do you get it?
Okay. Okay.
So, during expiration, now, you know that during expiration, there's tendency for the lungs to collapse due to elastic
Yes.
response. You get it?
Mm-hmm.
Now,
Yeah.
you don't want that collapse to happen. You don't want that collapse to
Okay.
happen. So, what do? You deliver a positive pressure at the end of expiration, so that at the end of expiration, it can keep those
It can
alveoli
collapse.
open. So you
Okay.
deliver it through expiration so that at the end of expiration, you still have something that can keep them open.
Open.
That's what you call
Okay.
the positive end expiratory pressure that is there to prevent closure of those
Alveolar
alveoli.
collapse.
Exactly.
Okay.
We have something we call the continuous positive airway pressure. That is different from PEP.
CPAP. Mm.
CPAP. Thank you. CPAP, the difference between CPAP and this guy is that in CPAP, you are delivering that pressure both at inspiration and expiration.
Inspiration.
So that means that you actually give CPAP in someone that has maybe airway resistance that cannot even bring in air. Shebi na person wey bring in air go dey get problem with dey bring am out.
Expiration. Mhm.
You get it? But in people that need CPAP, they cannot even take in that air. So we'll get to when we are going to talk about CPAP. So you need to deliver a positive pressure both at inspiration to help you drive air in and expiration to drive it out. Do you get it?
Mm.
And prevent it from collapsing.
Mm.
Yeah.
Mm.
Also, Dr. Rowley, if I understand what you're saying now, so the whole idea of having a positive pressure is so that there can be a difference in the gradient. Because I know that normally there's a negative pressure in the lungs, and then the chest, there's negative intrapleural, yes, that allows air to move into the lungs. But now that we are doing in someone with ARDS, and then we are giving positive outside. So that means that's like creating a gradient so that air can flow out of the lungs. Is that it?
No, no. That's not it. What we are not trying to make air flow out.
Can you can you relate it to the normal positive negative intrapleural this thing? The PEP. The PEP. So sorry. I'm trying to I know positive air with this thing, but I just want to be able to relate it to the normal physiology.
Okay. So this is the normal physiology.
Thank you.
This is the normal physiology. You know, the reason why you are creating a negative pressure in the intrapleural stuff is that at the end of the day, you want to increase the transpulmonary pressure. Once you increase the transpulmonary pressure, you make the airway open. You still remember that,
Mm-hmm.
doctor? Now,
Yeah.
how do you want to increase that transpulmonary pressure? Is it that you increase the alveolar pressure or you what? You make the intrapleural pressure more negative. Do you get it? So, because we've said that transpulmonary pressure is what? Alveolar pressure minus the intrapleural pressure. You see, the whole idea of this pressure, this PEP, is to prevent the lungs from collapsing. And what will
Yes.
prevent the lungs from collapsing is by you increasing the transpulmonary pressure. Do you get that? Because transpulmonary
Okay, I
pressure,
get that.
we've said it that is the one that keeps the alveoli open. During the early course of this discussion, we've said it that is the one that keeps it open. So there are two ways you can do it. Increase the alveolar pressure, that is the pressure within that alveoli itself. When there's increased pressure in something, it will not close, it will still be opened. Hmm? Or
Okay.
increase the pressure that is outside, and make the pressure that is outside more
Mm-hmm.
negative. Make the pressure that is outside more negative because Your transpulmonary pressure is the difference between the pressure that is inside and the one that is outside. So now in this situation, what we are trying to do, instead of making the one that is outside more negative, which is the intrapleural pressure, we are making the one that is within the alveoli more positive.
More positive. Okay. Okay.
Do you get it now? So
So the PEP thing is making the alveolar more positive.
more positive. Mm. We are
Oh,
delivering it
okay. So that means the intrathoracic, the outer one is always
negative.
negative.
That one is
It is
always negative.
always
It is always
negative.
negative.
Okay,
That
okay,
is it.
okay.
That one is always negative. So
So
in an individual that doesn't have problem with the lungs, that one is sufficient enough to keep
yeah,
it
enough to drive here to
exactly
keep the alveolar open.
open, to keep it
Okay.
open. That is it though. So
So
if
the idea of all this thing is just to ensure that the airway remains open.
open,
Okay.
yes, because
Okay.
in people
So
with
is it that
because in people with
I'm with
ALD,
you?
because in people with ALD, we said that they have alveolar collapse due to the what increased surface tension. And you remember that surface tension is a
Yeah.
force that is bringing it inwards, making it
Inwards, yes.
so that
Making it close up.
close up, making it close up. So
Yeah. Yeah.
deliver pressure within that alveolar that is more than surface tension, so that it doesn't close up. That's your PEP. Mm, exactly. So don't worry, don't worry.
Sorry. So I think
Just be
I've
taking
missed.
it small, small.
I've mixed it up again, Dr. Brawley. So alveolar pressure minus intrapleural pressure is the transpulmonary pressure, right?
Exactly,
Mm-hmm.
exactly.
Okay. So
So the,
sorry. Let me
okay.
just get it once and for. Sorry, Dr. Zidane, just a minute. I'm almost done. So that means we are making. Is it that you make transpulmonary more positive? Abi?
No, you make
No.
alveolar more positive.
Alveolar positive, transpulmonary negative, right?
Mm-mm.
Which one
The
are we making negative?
intrapleural, the one that's within the alveolar cavity,
Intrapleural.
intrapleural.
Okay,
But
negative.
you
Okay.
cannot affect intrapleural.
The transport. Okay.
You cannot affect because for you to affect intrapleural, that means you must be sucking air from the pleural cavity. Before you suck
Makes
it out.
sense.
So
Wait, and that intrapleural is what is surrounding the lungs.
the lungs,
It's now taking shape in my head. Sorry.
exactly. So it's like you are creating a gradient for air for like you to drive air towards the
Okay.
outside. If you make the one outside more
Okay.
positive, more negative, that means that you want to move air towards that outside. So in the process, you are going to be
Yeah.
expanding the alveoli. That is called what we call the transpulmonary pressure. That's why the direction of the transpulmonary pressure is always towards outside, so that it can keep the alveoli widened. Mm, that is it. Does it make sense to you?
It makes a lot of sense now. Thank you.
Yes. So
It does.
okay, I'm with you. I'm with you. I'm with you, Doctor Zulia.
No, I just wanted to add the way I was picturing it. Maybe it was going to help her. That the way I picture it in my head is like the intrapulmonary pressure is the one that is within the pleura, and like it's like you're pulling it outside, like you're pulling it outwards. The more you pull it outwards, the more air it can contain. So for the alveoli, it's like you're putting air inside it. So the
Thank
more
you.
air you put inside, that's like positivity. So if you pull the intrapleural pressure outwards, it's negative, and then when you pull more air into the alveolar pressure, it's positive. So that's
Okay,
what I
so the pleural is what is covering the lungs. So if you make
yeah,
the pleural pressure more, you kind of like bring it out more. So the lungs have more space to expand.
spirit. Yes, exactly.
Thank you very much.
That's what
God
I just
bless
wanted
you.
to tell you. Yeah.
Thanks. Thanks.
Yeah. So that's the way it works. So then another thing about the mechanical ventilation is that it reduces the tidal volume. So the reason why you want to reduce the tidal volume is that in someone with ARDS, there's still going to be some part of the lung that is going to be well aerated. They are going to be ventilated. So that's why you have that shunting. You have shunting of the blood towards those areas. Now, you want to reduce tidal volume in them so that you don't overinflate those already well aerated area. Because if you increase the tidal volume and you are delivering a lot of air load to those areas, you can have hyperinflation and eventually alveolar rupture. You don't want that one to, because mechanical ventilation, they are on that machine continuously. So you are now increasing tidal volume. So you deliver the air at a low tidal volume, but an increased positive expiratory hand pressure. That is what you do. So that is what your mechanical ventilation helps you do. To deliver the air with a low tidal volume, but an increased PEP. So another way you can also remember this tidal volume of a thing is that, when we're talking about changes for restrictive and obstructive disease, we said that obstructive one, you want to increase tidal volume and reduce respiratory rate. That in restrictive, that's the R. You want to
Restrictive, you want to increase the respiratory rate.
exactly. You want to increase respiratory
Yeah,
rate and reduce tidal volume.
reduce
So
the tidal volume.
which category are we putting ARDS? Is it restrictive or obstructive?
Say it again.
So
ARDS,
yes,
restrictive or
or obstructive. Which
obstructive?
one of it is it?
I think I want to put it in.
Should be
You want to
restricted.
deliver restrictive.
It's
Restrictive.
restrictive. You guys already know the obstructive pattern. Obstructive pattern is
Yeah.
only how many? How many obstructive patterns do we have?
Asthma,
Yeah.
bronchitis,
COPD.
COPD.
Asthma, what?
Chronic
Asthma, COPD,
bronchitis,
Chronic
emphysema.
bronchitis, emphysema, and what?
emphysema, and bronchiectasis.
Bronchiectasis. So those are the four. Anything outside those guys is restrictive. ARDS is restrictive.
Oh,
Hmm?
thanks.
So there's going to be restriction because of the fluid overload that they have. So in other causes of the restrictive, there's usually pulmonary fibrosis, mentioned sarcodosis or pneumoconiosis or Wegener's or idiopathic pulmonary fibrosis. There's fibrosis that cause the restriction. So here is the pulmonary edema that is causing that restriction. So it's going to have a restrictive pattern. So that means that you want to increase the respiratory rate and reduce the tidal volume, which will help them. Okay. So this is the X-ray finding. You can see the diffuse opacity within the lungs because of the edema, fluid accumulation everywhere, and that. Yeah. So sleep apnea, just from the name, sleep apnea. Apnea means cessation of breathing, particularly when it's more than 10 seconds during sleep apnea. So in people with sleep apnea, there's disruption of the sleep. So what happens is that when they are sleeping, they suffer those apneic episodes. They don't breathe for more than 10 seconds. There's something we call the survival reflex from the CNS that tends to wake the person up so that they will start breathing again. That constant waking and apnea is what makes the sleep disrupted. So those guys don't get enough sleep during the night. So at the end of the day, they experience what we call daytime somnolence. So they tend to compensate for those sleep deprivation that they experience at night in the daytime. So they wake up, they are tired, and they sleep during the day when they're supposed to be active. You can make the diagnosis by doing a sleep study, polysomnography. So a sleep study. So what are you going to see within the sleep study? You are going to see the changes that happen during the sleep phases, like the REM, the non-REM. You are going to be seeing, because it's going to be connected to respiratory rate, the heart rate, you know the oxygen level. So you can see everything, in real time as it's changing. So you are going to notice that, okay, they are going to be having a reduced respiratory rate at a particular time, and they are going to wake up again. You are going to see that, okay, these guys have woken up. You are going to see your beta wave, right? Can you guys follow what I'm saying? So they are sleeping, maybe they are REM or non-REM. You are going to see, okay, if it's REM, you are going to see the beta wave. If it's non-REM, you are going to see the delta wave, and you are going to notice suddenly that they are happening. So the respiratory rate comes down, or they are not even having any breathing. There's no changes on the oscillator that talks about breathing. So then suddenly you notice that they are awake again. You are going to see your beta wave, and they are breathing. Your respiratory rate comes up. So your sleep study will give you, you know, a guide to making the diagnosis. So what are the complications? Because of the fact that they suffer those apneic episodes at night, they are going to have hypoxia. So what can hypoxia cause? You guys already know the normal response of the pulmonary vasculature to hypoxia. There's vasoconstriction. That increases the pulmonary pressure. So they have pulmonary hypertension. At the same time, hypoxia increases sympathetic drive. So hypoxia has been noticed to cause increase in sympathetic drive. That's what's bringing about increase in the heart rate, increase in the cardiac output, bringing about systemic hypertension that people with sleep apnea can experience. So they have both systemic and pulmonary hypertension, but for different reasons. People that have hypoxemia have high chance of having arrhythmias. Very important. So arrhythmia can come from the hypoxemia or from the increased sympathetic drive that they exhibit. But it's more of the hypoxemia that causes the arrhythmia. And from there, they can have sudden death. So the hypoxia is going to stimulate the kidneys, the peritubular capillaries to release EPO that brings about erythropoiesis. So increased hematocrit is one of those things that you can find in people that suffer, apneic episodes at night. All right. So what are the types? What are the types of sleep apnea? Obstructive sleep apnea, central sleep apnea, and obesity hyperventilation syndrome. Okay. Obstructive sleep apnea is just talking about an obstruction at the upper airways. That is it. Think of anything that can cause obstruction at the upper airways. It's going to cause obstructive sleep apnea. What are these things? Someone that is obese. People that are obese tend to have high fatty tissue within their pharyngeal region, both at the nasopharynx and the oropharynx. So they have high amount of parapharyngeal deposits, in them. And people that have adenoids, adenoidal hypertrophy, especially children, they can also experience that obstruction of the upper airway. So when that is there, that means that it takes them to it brings about an increased resistance, to actually ventilate because of that obstruction. So they have an increased respiratory effort against that obstruction. Just imagine someone having a lot of mass, like high amount of tissue deposit within the pharynx. The pharynx has the nasopharynx and the oropharynx. The oropharynx is the one from the mouth that is leading to the trachea downwards, and also the oropharynx that's also leading to the trachea downwards. So if there's obstruction at that area, that means that you are not able to get air across those upper airways downward to the trachea. So because of the obstruction, they tend to, exert a lot of respiratory effort to overcome those obstructions. That respiratory effort that they exert brings about the snoring that you see. So some people with obstructive sleep apnea, one of the cardinal symptoms that you see in the history is what? An obese person or a small child that had adenoidal hypertrophy that experienced snoring at night. So because of the fact that they can suffer, hapnic episodes, is going to trigger the survival reflex that I've talked about. You guys remember the survival reflex that we said, which will bring about the daytime sleepiness from the fact that they want to compensate in the daytime by sleeping more. So the two main causes is obesity, which brings about increase in the fatty tissue around the pharynx, as well as adenoidal hypertrophy in children. So the obstruction can get worse, that they are no longer bleeding. So that can happen, and what you want to do for them includes variety of things. So you can suggest weight loss therapy for people that are obese, so that you can reduce those pharyngeal masses, and you can reduce resistance at the airway, and you can take in more air. You can do the CPAP, which is a continuous positive airway pressure, so that you can take in more air, and you can take up, because these guys cannot even breathe on their own during the apneic episode. So you place them on CPAP. So CPAP is not like a device that you attach to their nose when they are sleeping at night. So sorry guys, I failed to mention something. The reason why this obstructive problem actually cause this sleep apnea at night is that at night respiratory effort is even more reduced at night. So that is why they can easily suffer that apnea. So they easily suffer apnea because at night there's reduced respiratory effort more than at during the day when you are active. So the fact that you have a reduced respiratory effort at night, coupled with a resistance at the airway, can trigger that apnea. So that is that. That is one thing I want you guys to know. At during the night, that's why we call it obstructive sleep apnea. There's an obstruction, but it happens at night when they are sleeping. That's when they suffer those apneic episodes. So when they wake up during the day, the concentration of oxygen in their blood, in the arterial system, is actually normal. But when you measure it at night, when they are apneic, when they suffer those apneic episodes, it is low. So what you want to do is to recommend weight loss so that you can reduce those fatty tissue, or you place them on the continuous positive airway pressure, which can help them take in air across those obstruction and also help them take out air. So when they're apneic, they're always on their CPAP. They are not breathing by themselves. The CPAP is helping them, with the breathing. So they are taking in air with the CPAP, they are taking out air with the CPAP. You can place some dental devices that can help release that obstruction. Like they can help us arrange the maxillae, arrange the jaw, keep it open, you know, to reduce the resistance. So that's not very, very high yield, but hypoglossal nerve stimulation is very high yield too. Because if you stimulate the hypoglossal nerve, it will help you draw the tongue forward, particularly the genioglossus muscle. So genioglossus muscle is the one that, if you guys remember when we were explaining, I think they mentioned the genioglossus to be a geni, that once you maybe call that geni, it's going to move outward from the kettle. I don't know if you guys remember that statement in first day. They mentioned
Genie out of lamp.
out of the lamp. So the lamp is in front. The mouth of the lamp is in front. So that means that it brings the tongue forward. So it brings the tongue forward and help us to widen the airway a little bit so that you can reduce that resistance. Or you can do upper airway surgery that involve removal of those tissues within the pharynx. You do upper airway surgery to remove the tissues. So those are the treatment options: weight loss, upper airway surgery, hypoglossal nerve stimulation to stimulate the genioglossus to bring the tongue forward, or you place on the CPAP. CPAP is actually the definitive treatment. There won't be any problem when you place them on CPAP. So that is obstructive sleep apnea, obstruction that happens at night. You are just worsening the normal respiratory depression that happens at night, so which can trigger the apnea. And one thing about them is that the PaO2 is normal in the morning, in the day when they are not sleeping. It should be normal. They will not suffer those apneic episodes. They will not. Okay, so it's different from the central sleep apnea. These ones, the day, the night, PCO2 is low. Don't forget that PCO2 is low day and night, but it is more worsened at night because of the apneic episode, that because of the reduced ventilatory effort that is normally occurring at sleep. So that is it. So you are just worsening that um respiratory depression, that happens in the sleep. So I'm not saying that is what I'm trying to say, that respiratory effort reduces when someone sleep. I'm not saying there's respiratory depression when we are sleeping, but respiratory effort is not as high as when someone is active. So if you now have a problem with either the airway due to an obstruction, or there's a problem with the central nervous system, the respiratory center controlling respiration, then you have worsening of that um, respiratory reduction at sleep. Okay. So the next one is the central sleep apnea. That means that worsening of the respiratory inactivity or reduction in the respiratory activity at sleep, the worsening is actually coming from problem with the central nervous system, not the airway obstruction that we have in obstructive sleep apnea. So an example is the Cheyne-Stokes respiration that happens in people that have CNS injury or CNS disease like encephalitis or brain trauma, or someone with stroke, or someone that has congestive cardiac failure, or someone that is on narcotic that cause respiratory depression. So the way I want to explain this Cheyne-Stokes respiration is just to um, picture a graph that is showing crescendo, decrescendo. So there's let's see if we can get it online. Um, so the normal oscillatory part exactly. So this is it. So this is. Can you guys see my screen? So I think we just run
I'm
about
still
We haven't
seeing
projected it
the
yet.
FA.
the what? Oh, you see that's the problem of ah. You see, you guys know
That
what?
means you probably okay, you shared window, Abby. If it
Yes, I
is
shared
tab,
window.
Roman Sedan.
So I have to share tab to be able to see that tab. Don't worry, guys. So Cheyne-Stokes respiration is just talking about period of hyperactivity, then period of no activity of the respiratory system. Hyperactivity of the respiratory system alternating with period of no activity, that is apnea. Then again there will be hyperactivity, again there will be no activity. That's it. Instead of a normal tidal respiration, you are just breathing in, breathing out, breathing in, breathing out. But this one, hyperventilate, you are not, after some minutes you are apneic, the person is not breathing again, then subsequently the person hyperventilates, Person stop breathing again, hyperventilate, stop breathing. That's kinestroke respiration. Now, let me
Isn't it,
explain.
isn't it looking like the sleep apnea? It's still sleep apnea, right?
No, no, it's not. It's sleep. Yeah, it's a form of sleep apnea. It's a form of sleep apnea because
Mm.
they also have apneic episodes. Do you get it? They have apneic episodes. But this sleep apnea is not characterized by this one is different from obstructive sleep apnea because in obstructive sleep apnea you don't have hyperventilation. Do you get it? So
Okay,
when
hyperventilation.
they don't have the hyperventilation, but in central sleep apnea you have hyperventilation alternating with apneic period and hyperventilation. So we'll explain why. So that pattern is your Chenistoke respiration. So what is happening in Chenistoke depending on the cause? So people with heart failure, for example, let's start with people with heart failure. Now, one thing that is central to all of them is that the hyperventilatory response is exaggerated. The hyperventilatory response is always exaggerated in them. So, in heart failure, there's pulmonary edema, there is ventilation perfusion mismatch, the level of CO2 rises in the blood, oxygen reduces, that stimulates the respiratory center. They want to hyperventilate to bring out that CO2. Now, when they hyperventilate, to bring out the CO2 drops. There's a reduction in CO2. And you guys remember that it's happening at night. The respiratory system is also slightly depressed. So that means that there's enough time for CO2 to keep accumulating again. So because of the depression that happens at night, with the low CO2 that happened from the hyperventilation, the respiratory center do not quickly detect that accumulating CO2 because once CO2 has been reduced, there's apnea. You know, because okay, so let me say it well. So when CO2 is reduced, your breathing has to normalize, right? It has to normalize because you have hyperventilated, you have taken out the CO2. But remember that we are talking about the sleep one now, because we said it gets exaggerated at night. So at night already, there's already this depressed, this reduction in the respiratory effort. So that will also worsen that cessation, that reduced breathing that they have from when they have brought down the CO2 level to normal. So they are likely to go into apnea. That during that apneic phase, because your body metabolism continues, CO2 keeps accumulating, and CO2 gets to a very high level. Because we've said that the hyperventilatory response is always exaggerated in them, they pick up that CO2 level again, they hyperventilate to the extent that they bring CO2 to apneic level. That is, when you bring out CO2 to apneic level, that is, you reduce that CO2 to a level that the only thing that you can do in response to that CO2 is what? To stop breathing. Because if you continue hyperventilating, you know, um, uh, uh, sorry, what am I saying now? I think I've mixed it up. So they're hyperventilating, they are bringing out the CO2. So the CO2 reduces to a certain level. They stop breathing because they don't want to get CO2 below that level. So there's something we call apneic level for CO2. You must not bring CO2 below that level. So once you get to up to that apneic level, it drops. And that apneic level is achieved due to the hyperventilation that they have. Do you guys get it? So the way hyperventilation happens in people with CHF is that because in CHF there's reduced cardiac output, there's reduced perfusion to the respiratory center. So they are not quickly able to detect CO2 increase. So at the end of the day, you have accumulated CO2 and it will have accumulated to a very large portion. That is when they will now detect it. So the breathing response to that accumulated CO2 will be exaggerated, bringing about hyperventilation. When there's hyperventilation, the ventilation rate is more than normal. It's more than normal. So it brings down that CO2 to apneic level that will trigger cessation of breathing. During that period of cessation of breathing, metabolism is happening, CO2 is accumulation, but due to the reduced perfusion to the brain, they are not quickly able to detect those accumulating CO2 to quickly respond to it and bring it out. So it accumulates to a high level. When it gets to that high level, it's going to drive hyperventilation again that will bring the CO2 down to apneic level. I don't know if I've confused you guys. I know that I've confused you guys.
So it's the accumulation of the CO2 that now makes it that now triggers the respiratory centers back, but it
Exactly.
takes a while
It
before
takes a
they
while.
can sense
Yeah,
it.
yeah. There's something they call loop delay. There's that delay in that loop that's supposed to be keeping CO2 regulated. Because you know that CO2 is a major drive for the respiratory center, The chemoreceptors are
Yeah,
what are
yeah,
regulated. Yeah, so it's not
yeah,
really oxygen.
yeah.
So the problem in CHF is that they don't quickly deliver because when you pump blood to the brain that they can be detecting the level of CO2. Do you understand? So when blood doesn't get delivered to the brain, both the venous blood, the arterial blood is reduced. So they don't quickly detect the accumulating CO2. So it takes a while before they detect accumulation of that CO2. And when they detect it, they respond to it vigorously. The ventilatory response is hyper. Do you understand? Is hyper. Do you get it? So, hello?
What would you?
Oh,
Yeah.
we can hear you.
So the reason why we are now calling it sleep apnea is that, you know, the problem is detection of CO2. That is it. That is it. And the way you are supposed to respond to that CO2 is to hyperventilate. Now, you cannot now hyperventilate because you cannot detect it. Now, again, when you are sleeping, respiratory effort is also reduced. So that means that you have exaggeration of that problem at night more than during the day. That's why we call it central sleep apnea. Do we get it? So the central in that they cannot detect CO2, the sleep in that the respiratory effort is even far more reduced, you know, in at night, and CO2 keeps accumulating because they cannot do respiration to bring it out. Do you guys get it? So there's a reduced respiratory effort at night, making CO2 accumulation increased. These guys already have congestive cardiac failure. The increased CO2 cannot even be detected. If it wants to be detected, it's going to be detected later when it has increased a lot. So when they now detect that massive increase in CO2, they are going to hyperventilate in response to it. That hyperventilation is so exaggerated that it takes down CO2 to apneic level because your CO2 cannot be eradicated completely. The minimum it can go below is 40. You cannot have your CO2
But
more than
when you
40.
say it takes it down to, sorry to cut you. When you say it takes it down to apneic level, so that means at that point the patient stops breathing,
Yes, the
or
patient must
or
stop
it's
breathing.
it's the patient will actually stop breathing. Is
Yes,
that a normal response
that is
when
it.
CO2?
That is it
So
because
a patient can hyperventilate. A patient can hyperventilate to the level that they would actually start. They will stop breathing from
yes,
that hyperventilation. Wow.
you
Okay.
see, you
Thanks.
see, the reason for that apnea is that you don't want to take the CO2 level below that level. Do you understand?
Oh, okay. Okay.
Because
Okay. Okay.
Yeah,
So
CO2,
like,
because
CO2,
CO2 is the
oh, this
major
is like
trigger for
you
the
cannot let it.
hyperventilation.
You cannot
exactly,
let it go beyond this level. You've gotten enough out. So you
exactly.
just stop already.
You just stop
Okay.
already
Okay.
because you
Okay.
don't because CO2 cannot be zero. CO2 cannot be zero in the lungs. It can in the blood. It cannot be zero. So So once it gets to that apneic level, the respiratory effort must stop so that you don't take it below that level. That's what causes that apnea. And the reason is because they're hyperventilating. If they are not hyperventilating, they will have taken the CO2 to normal level in the alveoli. So they will stop at that portion and they will continue their breathing. Do you understand? They will continue their normal breathing. Do you get it? So it won't get to the level that they will be forced to stop
Uh,
breathing.
I do now. Thank you.
So it is the hyperventilation that is causing it. So this thing can be a little bit confusing, but that is the way you can understand it. So there's always a delay. You must always explain. So the reason why I was trying to mix it up in the initial statement was that I did not start explaining it with this delay in the congestive cardiac failure. It's very, very important. You must always mention that delay, that perfusion to the brain, to respiratory center is reduced in people with congestive cardiac failure. So that brain perfusion limit the ability for the respiratory center to detect the level of CO2 that is already accumulating. So it will accumulate to a portion, and that that accumulation of the CO2 is further exaggerated because at night there's little respiratory activity. So that means that there's high tendency of CO2 being even accumulated. So the accumulation, by the time the blood is now being delivered to the brain, they would already discover that there's a lot of CO2 here. They will hyperventilate. More than normal tidal breathing. That hyperventilation will try to bring that CO2 more than below the apneic level. It will want to bring it out below the apneic level. So once it gets to the apneic level, they will stop breathing. So that CO2 can accumulate again. So CO2 keeps accumulating, CO2 keeps accumulating. They are still happening, so that CO2 can keep accumulating. So by the time CO2 keep accumulating to a large level again, the respiratory center will detect it, they will hyperventilate again. So it's like a loop. They will keep being within that loop. That's it. So that's the sleep apnea that they experience. That's the chinostic. So a patient that's already experiencing chinostic respiration cannot. I've seen a patient having this respiration before doing house job. They don't stay too long. Within a day or two, they are dead. Once you're having that breathing pattern, it's a bad sign. So so then the CNS injury, the opioid, of course, in these guys already, you have depression of the respiratory center from the opioid, from CNS injury, you have the respiratory center from the medulla is likely to be damaged. They have little ability to detect CO2. They only detect that CO2 when it has accumulated to a very high level. You guys see that they actually follow the same mechanism. So they're only able to detect the CO2 when it has accumulated to a very high level. Do we get it? So when they detect it at that portion, they are going to hyperventilate, try to bring a lot of CO2 out. CO2 will want to approach that apneic level, they will become apneic. Giving time for CO2 to accumulate again from metabolism. As it's accumulating, they are not quickly detecting it. You know that if they have quickly detected it, they will have restored it back to normal. They will continue their normal breathing. But they will not detect it when it's still rising. So by the time it has risen to the maximum, they will detect it again. They will keep firing. The cycle happens. Do you guys get that of opioid and CNS injury now?
Yes.
So respiratory depression that happens in them, causing CO2 to accumulate, and the fact that someone with CNS injury, you already damage the respiratory center. So they have little ability to detect CO2 at normal, concentration. So that is that. So what we want to do for the central sleep apnea people too, during the apneic phase, to take care of the apneic phase, is to give a positive airway pressure so that I can keep air in and out, during the apneic episode, because they can tend to die at that apneic phase. That's when they can die. So you want to prevent that apneic phase from happening. So you want to give a positive airway pressure that can help you move out your CO2 in and out of the lung, and that can help you introduce oxygen also into the lungs. So that's that about central sleep apnea. Just remember, narcotics or stroke or anything that affect the respiratory center are congestive cardiac failure that reduce perfusion to the respiratory center. That's the two mechanisms that you can use to explain it. Okay, so obesity hypoventilation is also called Pickwickian syndrome. So this one is just obesity causing hypoventilation, but the hypoventilation is not coming from obstruction of the airway. It's not. It's actually coming from obstruction or abnormality involving the chest wall. You guys remember that when we were talking about restrictive lung disease, we said one of those things that can affect respiratory mechanisms or mechanics is what? Obesity. Do you guys remember when we were talking about scoliosis and obesity? So kyphoscoliosis and obesity affect the chest wall mechanics. So the normal respiratory activity of the chest wall muscles is impeded in someone that is obese, because your chest wall muscles are replaced by fats. So you cannot readily breathe in and out. So there's tendency of them having hypoventilation, someone that's obese. And again, when they're hypoventilating, there's increased accumulation of CO2 in the lungs. That's one, and in the blood. And again, it has been discovered that people with obesity hypoventilation syndrome, one of the mechanisms of their problem is, aside the fat impeding on the respiratory muscles in the chest, causing hypoventilation, leptin also blunts the response of the respiratory center to CO2. So both during the day and during the night, there's high level of PCO2 in them. So PCO2 is elevated during the working hours, during waking hours in people with obesity hyperventilation syndrome. And if you do the arterial blood gas at sleep, you are going to notice a reduction in the oxygen and an increase in the PCO2. So what you can do is just to treat the obesity airway, you encourage weight loss, and give them positive airway pressure so that I can drive air in and out and reduce the level of CO2 and increase the level of oxygen. So if you are seeing this picture of elevated PaCO2 in these waking hours and the person is obese, that's obesity hypoventilation, not obstructive sleep apnea. So you guys should not confuse it. Elevated PaCO2 during the day in someone that is obese, obesity hypoventilation, because they cannot breathe. That is the problem. So, and of course, the respiratory response to CO2 that's accumulating is blunted. So PCO2 accumulates in obesity hyperventilation. But people with obstructive sleep apnea, when they are out of sleep, when they are walking, there's no problem. Even though there's still resistance in the airway, but it's not exaggerated. That resistance doesn't cause CO2 to accumulate. They can still maneuver their way, but it gets worsened when they are sleeping. So your during the day, the level of their oxygen and their CO2 is normal, but during the night, at night, they snore, and the level of PCO2 is increased at night in obstructive sleep apnea. And one of the prominent causes of that is obesity. Obesity, apart from causing obstructive sleep apnea, can also cause obesity hypoventilation. These guys cannot breathe out and breathe in very well. They hypoventilate because the fat has replaced the respiratory muscles, in the chest. So the respiratory mechanism is impaired. They cannot breathe out and breathe in. PaCO2 increases, PaO2 reduces. Now, normally there should be a response to this PaO2, which is hyperventilation, so that I can bring it out. If of course the muscles are already impaired, they cannot even breathe out. And secondly to that, leptin has elevated up, blunt the respiratory response through PaCO2 that is accumulating. So both night and day, they have disturbance of those arterial blood gas. So of course, to the three of them, you can give a positive airway pressure, and the one that is involving obesity, give weight loss treatment to them. So do you guys get this? So if you guys see it in question, you must be able to find your way. Hello guys.
Yeah, yeah.
So do we have any question? I'm going to be stopping here. We are 22 minutes. Do we have any question, Dr. Abisola?
My
Okay, okay.
Doctor, my it is going to take us a little bit about, and it's going to be about the respiratory rate and the tidal volume. This thing about the restrictive lung
Disease.
and disease that we're supposed to increase the respiratory rate and reduce the tidal volume. I know that's what it is, but I just want to I want to have a deeper maybe understanding or something, or maybe I should just leave it as that.
Okay, so the reason is that if someone has, the problem in restrictive disease is not actually expansion. It's not actually the recoil, rather. I'm not saying expansion. It's not actually the recoil. So in obstructive, like COPD, there's damage to the elastic recoil. There's damage to the elastic fiber. So that means that they cannot have elastic recoil and bring air out. So there's obstruction at expiration, but they can take air in and accommodate air. That's why they are hyperinflated. But in restrictive, it is not problem with the elastic recoil. Elastic recoil is intact. That means that they can rapidly bring air out during expiration. But they cannot bring enough air in. Do you get it? So
Mm-hmm.
what we do for people with restrictive lung disease is to increase. Sorry, I'm trying to